Okay, for our final deep dive today, let's turn our attention to a condition that's, well, it feels like it's increasingly coming to the forefront in adult practice, even though it often starts in childhood. ADHD.
Yes, definitely seeing more awareness in adults.
It's the most common neurodevelopmental disorder. Affects roughly 10% of kids, maybe 5% of adults. And it's probably better understood now in a spectrum, rather than some rigid categorical diagnosis.
That spectrum idea is helpful, yeah.
It's largely inherited, though environmental stressors like premature birth can contribute. And its key features, as most know, are inattention, hyperactivity, and impulsivity. Interestingly, it's highly comorbid with oppositional defiant disorder, ODD.
Very high comorbidity. About 40% of primary school kids with ADHD have diagnosable ODD, and another 40% show significant features. Sometimes you can almost consider ODD as part of the ADHD presentation itself.
Okay, so what's really foundational to understanding an ADHD diagnosis? It's not just ticking symptom boxes, is it?
No, absolutely not. That's probably the most crucial point. You cannot make the diagnosis solely by fulfilling symptom criteria.
Right.
The symptoms must be associated with functional impairment. That means the person is genuinely unable to meet the expectations of their roles or commitments because of the symptoms.
Impairment is key.
And this impairment needs to be evident across 2 or more settings, typically home and either work, school, or preschool, not just in one place.
Okay.
It's also vital to remember performance in ADHD is often very task-dependent and variable. People can have good days, even if they're infrequent. This is a key difference from cognitive disabilities, where limitations are usually more consistent across tasks.
That's a useful distinction. So what does this all mean for actually recognizing ADHD across the lifespan in your busy practice? Let's break it down by age. Preschoolers.
Yeah, with preschool children, there's a real danger of overdiagnosing just because kids are naturally active. But you'd consider ADHD in children with really extreme behavior, often with severe ODD alongside it. Psychological intervention is remarkably effective at this age.
Okay. Then primary school children, say 5 to 10 years.
This is often the peak age for diagnosis, typically presenting with poor concentration that's clearly affecting their learning. Teachers are often excellent at spotting potential ADHD here, and sometimes the ODD can kind of mask underlying concentration issues.
Yes, the behavior gets noticed first. What about high school children?
Demands really ramp up then, academically and socially, so you might see declining grades, even in intellectually bright students. Hyperactivity often tends to decline physically.
Interesting.
Yeah, that hyperactive child might become a surprisingly underactive, maybe daydreamy adolescent. And there's an increased risk of substance use starting here too, maybe nicotine, used almost like self-medication for calming.
Okay. And then adults. Many were missed in childhood, right?
A huge number. Diagnosis often happens when their own children get diagnosed, or just as life demands increase a new job, relationships becoming apparent. You might see a lifetime pattern of underachievement, disorganization, impulsivity.
And that can lead to other things.
Absolutely. It often leads to secondary anxiety, depression, or substance abuse. So a really crucial insight for you as a GP, always screen for ADHD in adults presenting with these mental health conditions. Because if you miss the underlying ADHD, treating the anxiety or depression alone is often much less effective.
That's a huge clinical pearl. What about the elderly?
Likely the most underdiagnosed group. Problems might actually increase as cognitive decline, even normal age-related decline, starts to erode the coping mechanisms they've used their whole lives.
So what should you ask?
Ask about lifelong versus just recent problems.
Yeah.
How long can they typically focus on something like reading? And importantly, get observer input from family. Ask about changes in mood or anger, organization.
Right, getting that collateral information seems vital across the board.
Absolutely crucial. You really need to seek information from multiple sources. Teachers, old school reports as possible, parents, partners, maybe close friends.
So rating scales alone aren't enough.
ADHD rating scales are useful, sure, good for documentation, tracking symptoms, but they are far less helpful diagnostically than a really comprehensive history combined with that invaluable collateral information. It's like being a detective, you need all the pieces of the puzzle, not just the self-report.
Okay. And what about treatment for ADHD?
Well, the good news is treatment is highly effective for improving functioning. Most patients benefit significantly from a combination of psychological and pharmacological interventions.
So both together.
Often, yes. Psychological interventions, things like parent training for preschoolers, behavioral strategies for school-aged kids, they can be started early. You don't even necessarily need a formal diagnosis to begin those.
And medication.
Medication, typically stimulant medication, does require specialist assessment and initiation. but it's effective for both the core ADHD symptoms and often for that co-occurring ODD as well.
Okay. Are there other conditions to consider? Things that might look like ADHD?
Yes, definitely. It's vital to think about differential diagnoses and coexisting conditions that can mimic or compound ADHD symptoms.
Such as?
Things like vision or hearing impairment seems basic but easily missed. Learning or cognitive disabilities, the impact of trauma. Autism spectrum disorder has overlapping features sometimes. And as we've discussed, substance abuse can look similar or coexist.
So you need to rule those out or manage them alongside?
Exactly. Always rule these out or co-manage them. Ensure you're looking for the underlying reason for any behavioral similarities. It's about not just treating symptoms you see, but really understanding their root cause.
Right.